So now we're going to focus in Module 5 on autism spectrum disorder and some of the symptoms in this particular module, and then we'll get into the causes and treatment in our last module, in Module 6. So when we talk about autism spectrum disorder, we're talking about a disorder that falls along a spectrum of severity. It begins early in life and involves impairment in social interaction, social communication, and restricted or repetitive type behaviors. Now, about 5 or 6 years ago, when the DSM changed from DSM-4 to DSM-5, what we saw is a new labeling. It used to just be referred to as autism. Now it's autism spectrum disorder, and it encompasses several disorders that had previously been classified as pervasive developmental disorders, or PDD. And it included autistic disorder, Asperger's disorder, which no longer exists. That was subsumed in the autism spectrum disorder new diagnosis, childhood disintegrative disorder, and Rett syndrome. Now, most of you have probably heard of autism and likely heard of Asperger's. The other two maybe a little less frequently, but the people, psychiatrists who put together the DSM, decided that they were more a continuum and spectrum rather than an individual kind of disorder. And so it's the rare incidents where they actually collapsed a bunch of categories rather than splitting them up, as we've been seeing throughout our semester here, talking about various disorders. So some other things that you would want to know about the autism and the DSM-5, because they've included so many more of the disorders, it is a far less serious impairment compared to what it was prior to, where you had all these individual categories. And therefore, the prognosis is brighter, and comorbid problems like intellectual disabilities are less frequent than they had been before. And that's because they basically have collapsed several categories. Now, that's not to say that there aren't significant issues with individuals that have autism. And we can see that because the DSM breaks down 3 levels of severity. One is level, it requires some sort of support. Level 2 is substantial support, and level 3 is very substantial support. Now, this is qualitative levels of severity that you would measure autism on. On the most severe end, level 3, this can be characterized by very profound indifference to social relationships, odd kind of stereotypical behavior, and severe impairment or non-existent communication. And that's what you see in level 3. Now, the other thing that is, unlike some of the intellectual disabilities, especially with the chromosomal abnormalities, is the fact that you can have a pretty normal physical appearance and physical growth in general, and it's more the intellectual functioning, not disability-wise, but just the way that the information from the environment is processed is different for those with autism. That picture there on the left, the woman is Temple Grandin, one of the more famous individuals who has autism. He's a professor in regards to animal studies at Northern Colorado, and is pretty well known. And that's one of the actresses, I believe, for a movie that HBO made on her life, which is a pretty interesting view if you have some time, which of course a lot of us do during this point in time. You see some of the characteristics as we kind of break them down. One of them is the major areas that I talked about earlier, is an impairment in social communication and interactions. So in many cases, they're going to fail to develop age-appropriate social relationships because they have difficulty initiating and then maintaining these kind of relationships. And they have trouble with nonverbal communication. And so we know so much of our communication is based on things that we pick up on, like body language. So on one extreme, where you're talking about fairly decent functioning children with autism, you'll see that they may have odd body language, and that's really about it. And then on the other extreme, to that more severe end, a total absence of both verbal and nonverbal communication, really to others at all. Those that have autism that do acquire language often will speak oddly, and that's what we call dysprosody. And dysprosody is a subtle disruption in the rate, the rhythm, and the intonation of speech. Sometimes they may sound like they are robots, so you have a very flat kind of way of pronouncing things, and you don't have the pitch and tone that you typically have in most conversations. You may also see individuals with autism engage in echolalia. And echolalia is uttering phrases back, perhaps in a repetitive fashion. They may have seen a commercial on TV and then they repeat it verbatim, or they may just repeat what you have just said, and they just kind of get locked in that regard. Now, some other things that we talked about is this trouble with social reciprocity. So, communication takes two people, and especially in interactions. If you do not interact and seem engaged, then people will disengage from them. And so, there are a couple of absences that we might see. It's not necessarily in all people with autism, so it's not necessarily a core deficit, but it is a deficit in what we call theory of mind. And theory of mind is failing to appreciate that others have different points of view or points of reference. And so, for instance, if somebody takes a food out of the refrigerator, an individual is unaware of it and goes to look in that refrigerator for the food, we would assume, oh, they're looking there because they don't know somebody's already taken it out. But people with autism, if they don't have theory of mind, would not understand why they looked in the refrigerator because the food was already actually out. And so we see if you can't anticipate that others have different points of reference, you have a real trouble with social relationships, anticipating people, the way people react and such. Some children with more severe autism spectrum disorder may appear to even be missing basic motivation for human contact or attachments. And you may see them do gaze aversion, where they don't make eye contact when they're talking with others. Now, I got to be very careful about this. There are some cultural aspects. Some cultures don't want children to make eye contact with adults. It's a sign of disrespect. So you got to be a little bit careful in regards to that. A lot of people like to jump to the conclusion of autism if there is some gaze aversion, and that's not it's a little presumptive. Now, the slide picture there on the right, you can see is what we call eye tracking. And eye tracking is where they put a little device on individuals with autism that helps show where they're looking when there are conversations going on. And what they tend to find is that individuals don't spend a lot of time looking at people's eye gaze, or maybe they spend too much time on the mouth or other inconsequential areas of the body in when people are conversing, and so they're missing out on a lot of that nonverbal communication. So the next slide here just shows an example of where they did that research with a movie, and what they did is you can see that in the red there is a viewer with autism, a little bit of focus on the mouth, otherwise looking at aspects that really aren't going to help you in understanding communication. Whereas in those who have more typical eye gaze, you're going to see lots of movement back and forth between individuals' eyes and their faces, because there's a lot more nonverbal information that's located there. And so you can imagine if you're not focusing on the right thing, you're missing out on a lot, and therefore it's going to go more poorly when you're trying to interact with others. Another aspect that we see with autism is restricted or repetitive behaviors and interests. So they have a preference for status quo, in other words, a lot of maintenance of sameness. And in the more severe forms, you might see stereotyped or ritualistic behavior, a lot of times seen in self-stimulation. So one of the classic self-stimulations is this kind of flapping, hand flapping, and that they will get kind of fixated on the hand flapping. And what that self-stimulation does is it reduces sensory input because it maintains this stimulation that is monotonous and very predictable. And so if they have a hard time adapting to changes in their environment, you might see them self-stimulating. You can see spinning, rocking, or other kind of ritualistic types of behavior. Now, that's on the severe end of autism spectrum disorder. In less severe forms, what you see may be really intense or circumscribed interest in very specific objects or subjects. So you can see the child up above there obviously really likes trains. And what you see when you try to have conversations with individuals with autism with these more restricted interests is that all conversations tend to steer back to their area of interest. And they can talk ad nauseum about that. And so that is more the characteristic in higher functioning individuals. So a lot of times you see if they have a particular interest that they're locked in on, and everything else kind of revolves around their interest in that. Some other symptoms, now these aren't required for diagnosis, but can be characteristic of individuals with autism spectrum disorder. They may have particular or acute sensitivities to various sounds or touches or smells. A lot of times they'll have an issue with like tags. Nobody likes tags in shirts, but it can really unnerve them to the point where they just shut down. They may be very, very sensitive to sound. So what most typical people have no problem with, they may feel like somebody is screaming at them. In the most severe forms, you might see self-injurious behavior. Can be the most bizarre and kind of dangerous difficulties that accompany more severe autism. The most common forms of self-injurious behavior is banging the head or biting fingers or wrists. And these can create significant health issues, as you might imagine. That's why if you see some really severe autism spectrum disorder and they're wearing helmets, it's probably to reduce the damage from the head banging into walls and such. In rare occurrences with individuals with autism, you might see what's called a savant performance. And this is where individuals have an exceptional ability in a very highly specialized area of functioning. It could be the ability when you drop a bunch of toothpicks to count all the toothpicks. Could be a perfect recall of calendars, or it could be being able to play the piano, though they can't communicate. These are what we call savant performances. One of the things that put that on the map was a movie called Rain Man. It had Tom Cruise and Dustin Hoffman in it. If you haven't seen that, it's an interesting portrayal of someone with autism, but not a realistic one in the fact that savant syndrome is pretty rare and is not indicative of most children and adults with autism spectrum disorder. So this is just a general overview of the diagnostic criteria. I'm not going to expect you to know it, just to kind of highlight, though, what something like that will look like in the DSM-5. Really, as you can see, that part A is the deficits in social communication and social interaction that we discussed. The part B is restricted or repetitive patterns of behavior, and we also talked about that. And then the fact that autism is going to be manifested usually early in the developmental period, tends to be diagnosed prior, probably to the age of 5 or 6, and can be diagnosed as young as 2 or 3. Unfortunately, some of these characteristics you're not going to see or not going to appear abnormal until a child gets a little older, because a lot of very young children are going to have the very same type of deficits that you would see. As far as frequency, the CDC estimates that about 200 out of every 10,000 children will have autism spectrum disorder. You've seen a pattern of increase in the diagnosis of autism spectrum disorder over the last 20 years. A lot of that is not because we all of a sudden have this huge increase, but rather it's just increased awareness leading to more diagnosis. And the fact that when you collapse 4 categories into one category, you're going to also see an increase there. We don't think autism spectrum disorder is related to parental education in any sort of way. And we know that about 4 times as many boys as girls have autism spectrum disorder, and that it's more common among siblings of a child with autism spectrum disorder, suggesting that there is some sort of genetic link involved here. So on the next slide, you can see a variety of studies that look at the prevalence of autism spectrum disorder, and this is cases per 10,000 children. As you can see, when it was first diagnosed in 1940s, you have very, very few cases. But once again, this is even before it became an official diagnosis. And then as you see, over the next 20 years, not a lot of awareness, and it was really right in 2000s, late 90s to early 2000s that you saw a huge increase. And the most recent for this particular slide, you can see in 2013, all the way up to 200. which is a real jump from 2009, which was the estimate was 91. So in 4 short years, you're not going to get an increase like that unless, of course, it's due to the way you define autism, which is the case here. And that also means that there is a much better general outcome for children with autism spectrum disorder because we've broadened what that means. So in our last module, we're going to talk about some of the causes and then the treatment of autism.